please, please do, signify by raising your hand or by unmuting your mic, and then we'll be happy to hear from you. Also, if you join in as an attendee and you are representing anybody, please, you can maybe change to a panelist. Today, we are all part of the panelists today, and so we'll be happy to hear from everybody. If you are here, and I'm going to repeat again, if you are here for anyone to represent anybody or from any organization, please do signify by raising your hand so we can hear from you and get to know where you're from and who you represent. Thank you so much. And we're moving on to the keynote address. And this is going to be coming from the NHIA representative for Akwa Ibom State. Keynote address from the NHIA representative from Mr. Ebiokobo Williams, the coordinator for NHIA Akwa Ibom State. If you're on the call, please do unmute your mic as well. Just raise your hand so we can welcome you.
Larry, he just reached out that he's having a connectivity issue, but he will be on the call as soon as possible. So I think we can proceed. When he joins, we can then go back to him. Thank you.
Absolutely, absolutely. Thank you very much for that, Julius. So while we hopefully Mr. Williams sorts is the network issue, that we can get him to come and give us this keynote address. But while we expect him to join the call, we'll be doing a presentation from Mr. Julius Obumahai around the challenges experienced around state health insurance scheme in Nigeria, the setting up, the issues, what are the challenges, what are the, foreseeable, issues that we can, experience, and how other people have been able to surmount these challenges. Mr. Julius, are you ready with your presentation?
Yes, I'm ready. Joseph, can you please share your screen so that I can project? Thank you.
Cool. All right. So while Julius is sharing his screen and working on the presentation, I just want to use this time to say thank you for coming. Today, what we are to learn is around looking at the challenges around state health insurance, issues in Nigeria, and how we can overcome many of these challenges and ensure that people have access to affordable and then quality healthcare service across Nigeria. Julius Obumahai, please, it's your floor. You can zoom your screen so we can have a proper view.
Okay.
If you can move it to like a presentation mode, that will really help a lot.
Just a moment. Share. Can you see my screen?
We can see your screen.
Yeah. Trying to just give me a moment. Let me make it.
Yes.
Oh boy.
Well, if you're having issues with making it full screen, we can see your screen, and so you can go ahead with the presentation. That's fine.
Okay. So not to waste our time. So in Wellahealth, we've been able to prepare a report on the state of state health insurance schemes in Nigeria. It's a holistic one, and we're sure after this webinar, we should be able to get this report across to every attendee. So I will just attempt to do a summary of the entire report. It's actually a 95-page report. So I will attempt to do a summary of the report because I just have less than 10 minutes or so to do this. So the report will be looking at the executive summary, the NHIA Act, which is the anchor for the report, the NHIA gateway to the BHCPF, which is a basic healthcare provision fund, consideration for setting up our state health insurance schemes, state of state-sponsored health insurance schemes. We'll look at that. We'll look at the gains of state-sponsored health insurance schemes. We'll also be looking at the opportunities and future of state-sponsored health insurance scheme, and basically the conclusion. So the executive summary of the report, in bullet point here, we looked at the overview of state-sponsored health insurance schemes in Nigeria, the role in improving access to affordable healthcare. We also discussed the challenges, gains, opportunities, and future prospects. Also, the significance of the new National Health Insurance Act, the NHIA, the establishment of mandatory health insurance scheme for all citizens and legal residents. We also looked at the NHIA gateway of the Basic Healthcare Provision Fund, consideration for setting up state-sponsored health insurance schemes, and the importance of collaboration among stakeholders for accessible and quality healthcare in Nigeria. Sorry that my pace might be fast. I'm just trying to run through this. We'll delve into the main issues during the course of this presentation. For some of us that are maybe not too familiar with the National Health Insurance Act, and I'm sure the majority of the attendees are very familiar with this. So we were able to dissect the act, so discussed the new NHIA Act in Nigeria. The report also looked at the aim, which is to improve access to quality healthcare for all Nigerians. We also looked at topics like the mandatory health insurance provision, the NHIA establishment, the regulation of health insurance schemes, accreditation of healthcare facilities, subsidies for vulnerable groups. As we all know, of course, the NHIA tends to regulate the establishment of state health insurance schemes. The purpose is, of course, for every Nigerian, regardless of your state, to have access to affordable and quality healthcare. NHIA is seen as a significant step towards universal health coverage in Nigeria. The NHIA gateway, which is to the BHCPF, which is the Basic Healthcare Provision Fund, we explain the gateway to the BHCPF. It's actually a mouthful. Funding provided to primary healthcare facilities in Nigeria. Topics also discussed in the report also include funding sources, essential activities, challenges, and benefits. Also, the program expected to improve healthcare access in Nigeria. All these are contained in this report. We also looked at the consideration for setting up state-sponsored healthcare schemes. And I'm sure every state present in this call have their state health insurance already set up. Some might be functional, some might not be. Well, we do hope that at the end of this meeting, we'll be able to chart a new course forward to ensure that we have these things running in our states. So these are some of the considerations. We also looked at the topics discussed: cost, efficiency, adoption, and regulation, emphasis on careful planning, stakeholder engagement, and ongoing evaluation. We also looked at ensuring the effectiveness and sustainability of the scheme. Like I said earlier, there are some states that they've passed, of course, the state legislative arm has already passed the bill, but they are not functional. Some don't even have website that you can have access to. Some do. So I'm sure that at the end of this meeting, we'll go back to our respective states and meet the stakeholders, those decision makers, to ensure that we get this state-sponsored health insurance running effectively. Also, we looked at the current states of state-sponsored health insurance. Now, this state health insurance are sponsored by their respective states. So also looked at the complex and evolving nature of state health insurance in Nigeria, the challenges, which top of those challenges will be low awareness, affordability, limited coverage, quality of care, which has to do with the primary healthcare centers, and also administrative efficiency. It's a good thing we have the representative of the CMDs of various federal and state healthcare facilities present. They would be able to talk on this when called upon by the moderator later on. We also looked at the emphasis on collaboration among government, private sector, healthcare providers, and stakeholders. Of course, we also emphasize the need for government to collaborate with private sector, because governments cannot do everything, right? And that's where we come in. Especially those of us in the business of healthcare technology. We also address the challenges to improve the state of health insurance in the country, because we really, really need to address the challenges. Majorly will be enrollment. From this report, there is no state that have 10% enrollment rate compared to their population, and it's a far cry. And we will need to really address this. If the NHIA Act is emphasizing that healthcare should be for all Nigerians, they are pushing towards universal healthcare coverage, then it's a must that every state, at least we should be able to ramp up, because like maybe 50% of the total population, 100% might not be feasible, but at least. But now we have less than 10% of, enrollees enrolled in all the healthcare schemes in Nigeria, all the state healthcare schemes in Nigeria, which is not a good one. The report also looked at the gains of state-sponsored health insurance. Some of the gains will be increased access to healthcare, improved quality of care, reduce out-of-pocket expenses, increase awareness of health insurance benefits among Nigerians, positive impact of state-sponsored health insurance on the population. Like I said earlier, opportunities are abound here. This is actually a gold mine that is still untapped. And I hope that we will see that, or see this at the end of this. And also when we have this report, we'll go through it and see these opportunities. Some of the opportunities here will be enhanced healthcare access, financial relief, of course, to the vulnerable and low-income earners. We have improved population health, expanded coverage, integration with social programs. We have technological advancements, promise for achieving universal access to quality healthcare in Nigeria, which is actually the core mandate of the NHIA as it is. So in conclusion, as state-sponsored health insurance schemes improve healthcare access and affordability in Nigeria, collaboration is essential to address challenges and capitalize on opportunities in implementing these schemes. Careful planning and stakeholder engagement are crucial for sustainable healthcare improvements. The report is optimistic about the future of state-sponsored health insurance and its potential for achieving universal health coverage in Nigeria. What we have also done with this report is we looked at the 36 states, including the FCT. We looked at the enrollment rate. We looked at the population vis-a-vis the enrollment rate. We looked at the maternal mortality rate and also the infant mortality rate. I looked at the different insurance programs and the cost, which is very important, because if we want to provide affordable, keyword is affordable healthcare, we should really look at the costs. Of course, the different type of insurance programs cut across different states, from the private sector to public sector. So we did all of that, and at the end of, like I said earlier, at the end of this program, subsequently we would send this report to all the participants and make it also a public document, so we can look at this and look at our states and see how our respective states is currently faring. Then we will know if we are doing better in our respective states or not. All the stakeholders involved, the MDs, GMs of different states' health insurance agencies, the executive secretaries of state primary healthcare development agencies, and also the CMDs of federal medical institutions. We're all part of this. We have a role to play to achieving this. Thank you so much for listening. For more inquiries, you can also reach me on my email, which is, I mean, most of the attendees here, I'm sure I have your contact and you also have mine. So we can talk about the report, and how you can also have access to this report. And, whatever it is that I discussed here, you have any concern, you want to take the conversation forward, we will do that. Thank you so much, Larry. That's the end of the presentation. Thank you.
Thank you so much, Julius. Thank you for that comprehensive, like comprehensive summary, if there's a word for that, around the overview of the state health insurance schemes in Nigeria. And what this report has done, it's very encompassing. It looks at different states, compare different states together, look at what they've been able to achieve, what are the challenges they are facing, and how they can improve. And we'll send this to everybody that have been part of this event to look at and be able to improve on that.
So you change it to what?
So, ma'am, okay, yeah. So that's what the report about, and that's a summary of what the report contains, and so everybody will have access to all of the details later. So moving on, I'm sure Mr. Ikibo is around. Ebio Kobo, Mr. Williams, the coordinator for NHIA Akwa Ibom State. I think he's on the call now. Good morning, sir. Good morning, Mr. Williams. I can see you on the call. You can unmute your mic so we can hear from you. Yes, good morning. We understand that you had a network challenge the other time, and so we're happy to have you on the call. Mr. William Ebiokobo is the NHIA coordinator for Akwa Ibom State, and will be giving us our keynote address this morning. Good morning, Mr. Williams.
Yeah, good morning.
Larry.
Larry, okay, and all the distinguished participants on this call. First, I want to apologize for coming on the call a bit late. Just had a little network challenge from my end here. Yes, well, I was privileged to have seen what Mr. Julius presented. Can anybody hear me? Hello?
We can hear you loud and clear. We can hear you loud and clear.
Okay, great. So I came on when Mr. Julius was presenting, and quite a number of things have been said. And I must say that it's just in line with what we at NHIA, as National Health Insurance Authority, have been doing by way of, should I say, emphasizing the need for collaboration. Because prior to now, NHIA was NHIS, that's National Insurance Scheme. And of course, we know very well that our focus is to ensure access to care for every Nigerian, and to stress it, affordable, and of course, quality healthcare. And we realized, of course, there was no way as an organization who could do that being domiciled just in FCT, that's the Abuja, capital of Nigeria. So in wisdom, management decided to decentralize sometime in 2014, when we opened state offices in 36 states of the Federation, and including FCT, of course. And through that, structure, we're able to encourage states to establish their own health insurance agencies, where we give them templates of the kind of law. Of course, the focus then was ensuring that their own law would have the mandatory nature of health insurance, which we didn't have at that point in time. So with the collaborative efforts, a few states started it. Of course, it took a while. And fortunately, last year, May 19, 2022, the president assented to the new act, which is the National Insurance Act 2022, which makes health insurance further, to the extent that as we speak, I can say that 35 states, in fact, let's say 36 states have their bills signed into law, but of course at different stages of functionality of the health insurance agency, just like Mr. Julius said. Now, for NHIA, of course, we've been building capacity of these health insurance agencies, building capacity of not just the CEOs, but also the some key personnel in such in these agencies. And like you already mentioned concerning the Basic Healthcare Provision Fund, which is born out of the National Health Act of 2014, it's clear that, of course, this agency, NHIA, cannot cover the whole Nigeria on its own. We need to collaborate with the states. And of course, the states would have to cascade further to local government areas where you have the primary care centers. That's, as I always say, health has to be local. You have to start from the bottom, not the top to bottom, and from bottom to top. So far, yes, through our BHCPF gateway, that's the Basic Healthcare Provision Gateway for NHIA, we've been supporting the states' health insurance agencies, which I would like to call SHARE for short, to save time. So supporting shares spread across the country, particularly those that have functional structures. That is, they have office space and all the rest. At some point, we're going to have to install some means of communication with them, direct communication with them through VSAT and all that, just to be sure that we get information online real time concerning enrollment and the rest. Of course, what Mr. Julius said earlier about 10% of the population of the states have not been covered, I cannot verify that. But truth of the matter is that, yes, low coverage is still low. And that's why we have structures like the Ward Development Committees, WDCs, working with the SHARE in each state, and then the Primary Care Development Agency also. So the idea is that the WDCs are to galvanize the locals to ensure that we increase traffic to the PHCs. And of course, the PHCs in turn will get support through the Primary Care Development Agency of their state, through the BHCPF gateway of the National Primary Care Development Agency. So the idea is to strengthen PHCs over time, that it's actually a structured approach to it, certain percentage for every 2 years or 3 years, like that, until we get the desired structure that we want to see. And of course, people have access to care. So for me, what I would say in essence is that NHIA as an institution, of course, has been building capacity, coupled with the concepts developed by our esteemed DG CEO, Professor M.N. Sambo, where we have what we call health insurance under one roof. Health insurance under one roof, where, of course, the states have their role to play. We provide the legal framework, we provide everything that they need to work with, and then we ensure that, they tag along. Of course, we don't dictate to the states what to do, but we provide guidance. We provide guidance based on global best practices. So, of course, we get support from also international donor agencies, international NGOs, and the likes. So the whole idea is, yeah, people can have their reservations about the state insurance agencies in Nigeria, but I think it's a good way to go. It's a step in the right direction, as earlier mentioned, but it needs some strengthening. It needs the right support, particularly with the private sector collaborations where we're looking forward to have, not just in terms of putting money into the BHCPF, that's the Basic Healthcare Provision Fund, as we have it established by the National Health Act, but also providing, competencies in terms of experience and other supports that can come. So that's all I can say for now. As being a keynote address, is just to set the tone for other discussions that will follow. And I just want to say we should be, really open-minded and be frank about the facts we want to share, and hoping that, of course, after now, the states or state agencies that are on this call and other, facilities represented here would, be able to share ideas that can advance this course. That's my take for this morning. Thank you very much for your time.
Thank you so much, Mr. William. That was really deep. That was really, I think it attends to every aspect of what we are talking about today, which is affordability, having the right access, even the administrative part, and even the support. And that's why we are here today. To see how we can collaborate and support states that are struggling or that have not, kickstart their health insurance, and can even make it affordable and make it accessible. And even increase awareness, for, more enrollees. And that is so encompassing. Thank you so much, Mr. Williams. I'm really, really grateful. We know that we came to you at a very short notice, but you've done justice to, to this. Thank you so much.
Thank you. You're
welcome, sir. Like I said, for people that are just joining us, what we're talking about is, how we can collaborate and improve state health insurance schemes in Nigeria in terms of uptake, in terms of collaboration, in terms of administration, and also making affordable and accessible healthcare service across the world Nigerians. And so the key participant today, I've mentioned earlier the people we're expecting. And so if you are just joining the call, we would like to hear from you, your name and your affiliation. We'd like to, you can unmute your mic and tell us tell us your name and your affiliation. If you're just joining the call, we'll be happy to hear from you. Anyone from Edo, River State, Adamawa, Benue, Anambra, Kaduna State, Cross River, and Akwa Ibom and Ekiti. If we have anybody just joining that have not introduced themselves, we'll be happy to hear from you. Tell us your name and your affiliation. You can raise your hand and I'll be happy to call on you. I'm seeing Mr. Bala Saidu. Good morning, Mr. Bala. Good morning, Mr. Bala. We can hear you.
Hello, good morning.
Good morning, sir.
My name is Dr. Masigo Izadare. I'm the Executive Secretary of the Primary Healthcare Development Agency. Can you hear me?
Okay, good
morning.
I can hear you.
For which state, sir? I missed the state part.
I am Dr. Izadare Omasigo. I'm the Executive Secretary of the Edo State Primary Healthcare Development Agency.
Oh, great. Good morning, sir. Good morning, doctor. You're welcome. We're happy to have you on the call. Thank you very much, sir. You're welcome, sir.
I would indeed like to make comments later when others finish making their call introductions. Thank you.
Absolutely, sir. Absolutely, sir. Thank you very much, sir. Mr. Bala,
okay, good morning. Yes, good morning. I'm by name Pharmacist Saidu Bala. I'm the Director Planning Research and Statistics, Kaduna State Contributory Health Management Authority. Welcome.
You're welcome, sir. We are happy to have you on the call, and good morning to you as well. Do we have anybody just joining us that want to introduce themselves? We'll be happy to welcome you to the webinar. Thank you very much. Dr. Izedomain, you said you want to make a comment.
Yes, yeah, thank you. Sorry again for jumping in late. I jumped in when the previous speaker was talking, not the one immediate, not the NHI lead.
Yes.
And what I want to talk about is the low enrollee, issue. We still talk about. Sorry, there are other mics open.
Mr. Suleiman Mustafa, you can please help us mute your mic for a while. We'll come to you. I can see your hands up. We'll come to you. Can you help us mute your mic? Thank you. We'll come to you, sir.
Okay, so we do have a challenge with that. And my thinking is that we as a people will still, permit me to use this, it may not come out nice, we're still suffering from the hangover of, tertiary institutions as the place of care. All right, that's why most of our capitations go to tertiary institutions, to areas where, the big hospitals. But if we reverse that or make allowances for the primary care or primary health care centers, you see our capitations go up, or our, enrollment go up. The BACPF 300,000 per quarter can't do nothing. You can't improve services with that. So as a nation, we need to do a rethink and look at our direction towards health, the investment, where are we putting it? In other climes, the primary care or primary health care is the entry and only entry point. That's where they invest most of their money. That's how to secure health. But we keep investing in secondary and tertiary care. So we're not gaining traction. We're not dealing with the health issues, as it were. How much of our resources are we putting in primary health care? We need to look at that and take those very painful decisions, but needed decisions. I would advocate, like most people before me have advocated, primary healthcare capitations. We should look at how to pay primary healthcare in capitation sense, the way tertiary hospitals are being paid. That way, there will be reasonable investment in the primary healthcare. That's the only way we can puncture this enrollment thing. If still till today, most times primary healthcare is still seen as the care for the poor, for the not-haves. But that's not correct. We need to change the narrative that it is the only pathway into the healthcare. The tertiary hospitals should now be referral hospitals. Tertiary hospitals should not be running primary healthcare centers. It's killing our initiative as a nation. Nations who have improved their health status, their life expectancy, did that as primary healthcare level. You don't have to treat pneumonia. You can treat common cold first. You can treat nutrition first and improve on those things so that you can save people's lives. At the time the people start rushing to tertiary hospitals, they're already dying. Let's change the narrative. If we don't do that and you put the right investment, we won't achieve much, not in the enrollment. If people don't find primary health care attractive enough to enroll, to get treatment by walking across the street, they will not enroll in health insurance. The idea of health insurance is that when you're sick, you can easily walk across to your health provider. The idea of running to a tertiary hospitals will not make it attractive for people to enroll. These are my thoughts, and I hope we'll look at it from that perspective. When healthcare is distant from people, they will not find it attractive, no matter how colorful we paint it. I hope that we'll look at it strategically not because I'm head of a primary healthcare agency, but because I am a strong stakeholder in the enterprise of health in Nigeria. Thank you very much.
Thank you so much, Doc. Before you go, please, I have a question, sir. Not like a question. We've seen that Edo State health insurance, scheme is one of the success stories that we've heard in recent time around, the enrollment, the management, the claim process, even the administration. And we are actually very impressed, to hear this. What can you say has given you that, that's what can you say around that? What has made that successful, where other people can emulate them?
You haven't even seen anything yet. Wait, give us a little time, and then you guys will come sit down in Edo State. No, I'm not joking. You come and sit down in Edo State and bring your notebooks and copy. All right? What we're doing, interestingly, the DG of the health insurance in Edo State and I are good friends. So we've taken our friendship from a social level to a work level. All right. So what we do is that we sit down and say, how do we give health to our people? All right. How do we give health to our people? At every time we knock at the door, we're preaching health insurance, because that's the only way we know we can drive this. Health insurance is sponsoring programs for the primary health care. As we speak now, we're having as I speak to you, we're having a joint training to bridge knowledge improvement. And this is what we do regularly. Just give us time. In another year, I am saying this and I'm boastful of it. Most of you would come to Edo State with your paper and biros to come and copy. And this is what we advocate. There must be a strong collaboration between the health agencies and the primary care agencies, because that's where the action is. Until we remove our minds from that and start running to tertiary and curative areas, you will not see participation. The woman that is pregnant that is next door wants to walk into a hospital quickly, not take a bus, not take a bike. Until that pregnancy becomes complicated, an ambulance should move her. We have no business moving to a tertiary hospital. Thank you. I don't want to reveal our secrets here first until we start hitting the ground. Thank you.
Thank you so much, Doc. You don't have to. We are coming to Edo State with our books, with our pens, and with our bags. Thank you so much, Doc, for that. It's very comprehensive and it's very, mind-opening. We've seen that tertiary facilities are being clogged up due to the fact that most of the health insurance and everybody's just trying to go to the hospitals, neglecting the primary health care centers. And if we improve on those facilities, we'll see a lot of enrollment, and that's the reason why we are on this call today to emphasize, to open up the challenges, open up opportunities, what we are not seeing and how we can improve in other states. Thank you so much, Doc. I can see Dr. Rock, your hand is up. Good morning to you. You're welcome.
Hi, good morning, sir. Dr. Omo, everybody, good morning.
Good morning.
I came in late because we're having some challenges with our internet, but thank you, Dr. Omo, for all that you have done and all that you have said. Maybe I'll let other people speak first before I eventually speak. So thank you for having me.
Yeah, you're welcome, Doctor. So if you are just joining the call and you've not introduced yourself, please let us know your name and your affiliation. We'll be happy to say welcome and greet you appropriately. You can just raise your hand and I'll call on to you. Mr. Suleiman, good morning. We'll be happy to hear from you. Good morning, Mr. Suleiman. We can unmute your mic and introduce yourself, sir. Good morning, Mr. Suleiman. If you can hear me or if you are speaking, we can't hear you, and so we'll be happy to.
Okay, while we are waiting for Mr. Suleiman, maybe I can introduce myself. My name is Dr. Rock Amego. I'm the Director General of the Edo State Health Insurance Commission.
You're welcome, Doc. We're happy to have you. Thank you for obliging us. Thank you very much. You're welcome, sir.
Thank you.
See, yes, sir. I can see Mr. Simeon Oyemechi. You can unmute your mic and say your greetings to us. Also, Amza Ikara. If you're on the attendees list, you can opt in to be a panelist, and they will be able to hear from you. And I can see Amos as well. Your hand is raised. Introduce yourself, and we'll be happy to welcome you. So we're moving on to the panel session. And like I said earlier, we are all panelists. This is not webinar or a conference where we select people to come and talk. We are all a panelist to this conference, and so we all have opportunity to say one or two things about the challenges we're experiencing, the success stories from what we've been able to do, how we can collaborate, and also how we can improve on this enrollment, improving the healthcare facilities, improving administrative bottlenecks, and also ensuring that we provide affordable and quality healthcare service. And so if you are not on the panel list, you can, move on to the panel session. And just request, and then we'll grant you that request, and then we can also, welcome you appropriately. Amza, I'm still seeing your hand raised, and also, yes. So please move on to yes. Amza, you can talk now. Your mic is muted. Yes. Mr. Abdul Samadu Ainde, you want to say something? Your mic is on mute. All right, so we are going to move to the panel session, and here it's just for everybody to say one or two things. And my question will go to, hello, good morning.
Hello.
Yes, we can hear you. Good morning.
Yeah. Hello, can you hear me? The network is a little bit. Okay, yeah. My name is Dr. Abdusamad Nouraidi. I'm a family physician at the National Hospital, Abuja. I'm representing the CMD. Yeah, I've been listening to the discussions, and one of the ways we can actually improve enrollment into the state, not just the state health insurance programs, the whole health insurance programs that's brought out by the NHI. One of the areas we have not been able to actually improve upon is putting qualified and skilled staff at the various primary medical centers or the primary healthcare centers. Now, with respect to what one of the earlier speakers said, for us to be able to improve the enrollment, improve and have a huge number of people trusting our health services or centers as it obtains at the primary healthcare centers, we need to employ people that are qualified, people that are skilled, people that the patient can trust. Most times people rush to the secondary and then the tertiary health centers because we only have chiefs and some other cadres of healthcare workers at the primary healthcare centers. And this cuts across the whole country. So for us to be able to improve, we need to employ staff that are well trained. And with this respect, I want to mention that family physicians who are trained to offer comprehensive, coordinated, and continuous health services, right from the primary to the tertiary health centers, are very variable in this regard. If each state primary healthcare board can employ at least for a local government a family physician, who will coordinate activities at the primary healthcare centers, it will be very, it will go a long way in improving healthcare delivery at this primary healthcare centers. And this will build the confidence, increase the confidence and the trust of the citizens in these health centers, and it will improve the enrollment. So I think it's something that we have to look into. It's not just about putting a physical structure, renovating and putting equipment, re-equipping or equipping the facilities. We also have to put people that are skilled. And we have to look in the regard of family physicians. Most times they provide primary medical services at the teaching hospitals. The primary centers, which require the skills of family physicians, are actually devoid of the skills and the acumen of family physicians. So I think that we should look into this, and then each state should employ a family physician, at least one for each local government, who will coordinate activities of this local government. And if that one can happen, then we are sure that the health service of these areas will be improved and people have confidence in the system, and then enrollment will improve. Thank you very much.
Thank you so much, Doc. That was you've actually kickstarted the panel session. We're happy to to hear that key part of insurance services in Nigeria. If we have the right people in the right place, it will improve adoption, it will improve confidence, and people will start seeing the reason why they need to go to a particular stage of facility at any particular point in time. Thank you so much. That I'm there, Doc. We're happy to hear that. And so that takes me to the question. And this question is for is for the whole house. Like I said, we are all panels, and then anybody can pick up the mic and talk about it. Coming from what Dr. Abu Samad just mentioned around having the right persons. How can we overcome the challenges in administrative efficiency, in many of these federal and state health facilities? Because, having the right people is a function of administration, hiring and putting people in the right place. How can we improve administrative challenges and improve efficiency in administration to ensure that we have people in the right place in our federal and state health facilities? Anyone? Anybody can pick up the mic and talk about it.
Good morning again.
You're welcome.
Dr. Rock on the line. First of all, let me appreciate my colleague, Dr. Abdul Salamat, that just spoke. He's a family physician, and also my very good friend and also colleague, Dr. Omo. I think the reasons that both of them gave for the low enrollment in our various centers are very germane. But there's something that I think has a very strong background to having more people enroll in the health insurance, such that across the value chain, from primary health centers to secondary health centers, tertiary, and even ancillary services, we can engage them. One of the strongest backbone would be technology. All right. So using technology from end to end, and that's why one of the ways we've gotten success in Edo State. We've been operating our health insurance for the past 18 months, and we've gotten over 150,000 plus enrollees. And that's about the fastest growing health insurance in the country. I mean, thinking of the time where we started giving service and what we've been able to achieve. But this achievement hasn't gone, no, it's not alone. We have not been alone in doing this. What we've done is that we brought technology across the various spectrum. One of such technologies is telemedicine and also mentoring. All right. So if you look at the health space in Nigeria, for example, you know that we have a deficit in manpower. All right. We possess, this statistic was taken about of the manpower in health space, but we have 24% of disease burden. All right. So I'm sure that the gap would have increased now, especially when you think of the Jackpot syndrome that is happening in the country. So one of the ways we build this to stop this gap, where when enrollees go to the facilities, they cannot access a doctor, is to use bridge it by using telemedicine and telementoring. Telemedicine, someone can come to the primary health center and a doctor from a distant area can see them. All right, telementoring, when you have maybe a CHU or somebody who's not so familiar with all the spectrum or dimensions of care, like the family physician, you can employ a CHU so that when they are seeing somebody, when they get to a difficult situation, they can quickly scale up. All right. In medicine, there's what we say that do no harm. If you can't do good, but do no harm, at least let the patient remain at status quo. Also, those are also one of the ways we're doing, to get more enrollees on the scheme. But also, largely, what we did also is that we engage private and public sector. and again, ancillary services. So across the spectrum of care in those states, people can just go to the pharmacy sometimes and get their drugs, especially when their drugs are not available within our facilities, all right? When they want to do investigation, I can also go to diagnostic centers to do their investigation and then take it to any of our referral centers, all right? So we have an ICT system that is very strong. So when you have a medical officer, for example, in a particular area who has a proficiency in CS or can do a lot of, medical skills, as somebody where the enrollee has been referred, you look at the proficiency of a particular doctor in a particular place. And so at the back end, we're able to say, who do we refer this patient to? So basically what we're doing here is that we're just trying to use the available resources to get to the goal and achieve universal health coverage. I talked about telemedicine, I talked about telementoring, and we're also doing some form of rationalization with our healthcare space. All right, a lot of people do not want to go to the rural areas. The reasons are not far-fetched. There are no facilities for their children to go to school. There are no banks. There are a lot of amenities, social amenities are not there. So it will be difficult for you to say a doctor to go back there. But if they can't go back there, at least they can use virtual means, all right, to see our enrollees. And with primary centers where virtual means do not exist, we can now start doing some rationalization. Okay, say on a Monday, and then the chronologist is going to come and see you. On a Tuesday, a surgeon will come to that facility. On a Wednesday, so this manpower we have, they are going around the various primary health centers and facilities to see our enrollees, just to bridge the gap between short, like a short and medium term fix until we have a long term fix. It's a holistic approach. ASU was on strike for about 2 or 3 years. Imagine the amount of numbers of health service providers would have churned out. And that's also creating gaps in what we have. So again, we need government intervention, we need public and private sector intervention, and it's a continuous advocacy and sensitization as it has to do with enrollment into the health insurance. The testimonials are what is going to drive people, to join the health insurance and then have a high retention rate. Like Dr. Omo rightfully said, we have to reduce the burden in secondary and tertiary institute. And one of the good things we are doing at those states is that we're employing doctors, at least one doctor in each ward, in each facility in the local government. For exhaustive, for example, we have 192 wards. And so in each ward, we make sure that we have a doctor. We've done about 40% or 40 or about 50% of that. And we're scaling up, and I employ other states to also do that. And then lastly, these kind of webinar sessions are very great for us to improve our knowledge. Peer-to-peer review is key. All right, there are a lot of things that I've learned from many of the state health insurance across the country, Anambra, for example, and many other states. All right, it's because you do some of this peer-to-peer review, we see our success stories, we see our pitfalls, and then learn from those our experiences. So by and large, universal health coverage is a moving goalpost. Until we achieve universal health coverage, we'll begin to bring out innovative ways where we can achieve, large numbers in the health insurance space. I thought that I should add that to the submission of everybody. Thank you very much.
That was just perfect, sir. That was just perfect. 150,000 enrollee in 18 months. I've never heard of that. I've been in this space for years and I've never heard of that. Never everywhere. And I'll give it up to Edo State for the amazing work they've done in terms of collaboration, improving, leveraging technology for access and also for claim process. And Mr. Williams mentioned that earlier when he talked about collaboration. And Mr. Williams, I just want to ask a question, and this is to anybody. What does it take to be a partner in this universal health coverage drive? Who are the likely partners? What do we need? What I'm trying to ask is, how do we collaborate? Who should collaborate? Where do we need help? Where can we get help? In terms of giving people access to this universal health coverage. Anybody on the call? You can pick up the mic and talk about it. Yeah, don't just pick up the mic and just unmute yourself and talk and say something. Yeah. Dr. Hamza, you can go ahead, sir.
Yeah, good morning. I'm Hamza from Kaduna. Hello, can you hear me?
Loud and clear.
Yeah, okay. I think for the collaborative ways, I think we devised one means now for the complete involvement of our WDCs, that's the World Development Committees. And secondly, here in Kenya, we have the CBs, that's the community volunteers that we are, was over 8,138 CBs across the 23 local government areas for community mobilization across the local government for PSC service delivery. So we train them, we discuss with them how to ensure that people are much aware about the health insurance scheme across their community so that we get higher number of enrollees, because we realize that our enrollees are very low in the state. So these are the two ways that we have put now in place to collaborate with these people so that at least the enrollment will be high across the state. Over.
Thank you so much, Dr. Hamza from the United States. Anybody else wants to say something about that? That was great. Thank you so much.
Well, again, Dr. Zedana Omo from Edo State. Dr. Hamza, thank you very much. See, health is about people. And one of the mistakes we make is that people don't know what their deficiencies are. And so we go there with the toga of we want to teach them. The people know what their problems are. We probably just need to sit down with them and have a discussion on how best it can be solved. And so engaging communities is one of the programs that the Edo State Primary Healthcare Development Agency is embarking on. We're strengthening our WDCs to the extent that the WDCs take ownership of our primary healthcare centers. We can't monitor all our primary healthcare centers cut across the state. So what we have done, we've had meetings with our WDCs, and we intend to continue having those, strengthen them, let them know their responsibilities, their roles, and things they can do. And if you do this, you will see the numbers go up. Once I said that we're sure that very soon you guys will start coming to Edo State to learn what we're doing. We intend to enumerate all our communities. And how do we want to do that? We want to use the WDCs in conjunctions with the community health extension workers to knock on people's doors and preach health insurance to them and give them health. That's the only way we can ride on this. Once we knock on their door and they open, we enroll them in health and they go to our facilities and they see that we're doing well, they will not have the need to run to tertiary hospitals. We would treat them of minor cold and fever adequately well. Like Dr. Rock mentioned, our goal is to have at least one doctor in each ward of the state. Currently, we just employed about another 20 new ones in addition to the 30 we already have in place. So we're doing at least we're doing quite well with that. No, we already had 50. We just added another 20. We just employed 243 staff altogether, and we're placing new adverts again. We intend to take primary healthcare to the next level, such that people would find joy going to primary healthcare centers, and then as soon as they find that, they would find out that enrolling in health insurance actually is giving them value for their money. And this would be my recipe. Work with your ward development committees, empower them, and teach them their roles and responsibilities, and watch the ball just play on. Thank you.
Thank you so much, Dr. Omo. That was really, really touching, because we can't do this without engaging everybody, all stakeholders, and ensuring that they are fully functional, and that will really give us the result that we all want. Thank you so much, Dr. Omo. I can see Bala Seidu raising their hand. You want to say something? The floor is yours.
Okay, thank you so much for the opportunity to speak. You see that I just want to make some comment on the presentations or the concern raised by the Edo State Primary Healthcare Board representative. And I think one thing good with health insurance is that it opens way to strengthening PHCs. Why am I saying that? I don't know how it has been practiced there in Ido, but here in Kaduna State, every enrollee must choose primary facility as his own primary provider. So this is just to change the narrative of how the health system been operated in the country, whereby somebody will now feel sick. The first way to go maybe is to go to secondary facility or to go to the tertiary facility. But once you are enrolled in health insurance, no matter how big you are, you have to first visit your primary provider, which now provide the primary level of services. It is when it goes beyond their own care that they will now refer you to the secondary or or to the tertiary as the need may arise. So honestly speaking, this kind of initiatives and conjunctions with the state health insurance, particularly the social health insurance, and then the primary health care board, to strengthening their collaboration and to see how more people will be enrolled into the scheme and impanel into the PHCs is one of the best way to strengthening and even to rejiggle the entire health system in the country. So I think health insurance is the way to strengthen primary health care facilities in the country. Thank you so much.
Thank you so much, Bala. In all of the conversations, we've been talking about, the primary healthcare centers has been like, it has been recurring, and that shows that, we really need to, improve on our PACs so we can also get enough or more enrollees to be able to adopt health insurance. Dr. Betty Agala, your hand is raised. The floor is yours.
Thank you so much. Thank you, everyone that has spoken. I was just going to be quiet because Rivers State is one of the states that hasn't really commenced our health insurance program. But since we're talking about primary healthcare and strengthening primary healthcare, I wanted to say a few things because in Rivers State, the primary healthcare system is strong and it's working. I heard Dr. Rock, my good friend, talking about them having to engage doctors, at least a doctor per ward. For us in River State, our primary healthcare system is strong such that we have model health centers across the 23 LGAs, and we have medical doctors in almost all of our model healthcare centers. So for human resource, we do have them, even if we don't have all the right mix, but we do have capacity for provision of healthcare at the level of the LGs. So I want to believe that when the health insurance starts, and hopefully soon, one of the things that would help in creating demand and in ensuring that our people enroll is some of the things that the people that had spoken have said. But reaching the communities in River State, and I believe in all states, we have the health promotion officers that are also they also have one in each LG, I think, and the state health educator and all of that. That structure is a powerful structure for communicating, say, the benefits of health insurance, which is something that people need to know. They need to be educated. Many studies have shown us that people are really not educated. They don't know. They don't know the value that health insurance brings. They don't know what they stand to gain and all of that. So they need to be met. And we are looking at, if we must move towards the universal health coverage, then we must, of course, move away from just having formal sector people on our scheme. We also need to look at the informal sector, and that's where community engagement comes in. So we need to do a lot of collaboration with the community organizations, religious institutions. There are churches and religious bodies that you go to, even the Muslim community here. Once you have communicated to their leader, you find everybody following suit. Once their religious leader tells them that this is the way to go, traditional leaders, just on the side of getting influencers to influence community members to sign up and enroll in health insurance programs, while we on the supply side are trying to ensure that we can build trust and credibility, by the kind of services that we provide, ensuring that when they come, they get the right human resource. Looking at them, some people go to tertiary or secondary because they don't have a doctor on ground, so they feel like maybe the CHU or the nurse does not know or cannot handle what they have come with. So when they come, and whether it's via telemedicine, as Rock has said, or any which way, but they have their problems sorted. They have the drugs that they need. They are not told that drugs are not available or go and buy. Meanwhile, they are already signed up for the health insurance. And so we try to balance both the demand side, ensuring that we're reaching out, ensuring that we're having those conversations, maybe having some kind of financial plan that suits them, probably that they may not have to pay all at once or something, just something that would suit those levels of people. And then also working with artisan groups, maybe farmers association, vulcanizers association, those kinds of group. A lot of group market women, they form groups and they are able to access different services as a group, and so they can have their people enrolled in the group. So I think that these are some of the ways, and many more really, if we explore, that we can get people to enroll into the health insurance program. And of course, also as we continue to provide quality, we retain them going forward. Thank you very much.
Thank you so much. That was really, really, comprehensive. And then you made us understand, and there's a lot of points in what you just pointed out. And one of the things that tapped me is around enrollment. We mentioned what we need to do in terms to improve the PACs, enrollment, ensuring that they get quality access and quality service and all of that. But what got to me is the enrollment part. What are the strategies we can use or we can employ to enhance awareness and even enrollment? Because so I'll give an instance. The first time I saw the federal capital, the Abuja HIS, the health insurance, I saw it in the banner on the expressway. And I'm asking myself, also, how do I enroll to this? What does it take? Many people do not really understand. What are the strategies we can employ so that people that really need this health insurance service will be aware of what it takes to enroll, how to enroll, and how can we make even enrollment even much more, stress-free. If you want to do any health insurance now, you have to fill a lot of paper. You have to sign a lot of things. You have even the payment system is even a challenge. But how can we make this process more, awesome, more affordable, more easier than what is, currently out there? Anybody on the call that want to answer to that?
Yes. I think my hands have been up.
Oh my goodness! I am so sorry.
The first session
okay.
is to improve access to care.
Okay, please, just go ahead with the answer to the improvement of access to care. And if you have contribution to the enrollment, we're happy to hear from you, ma'am.
Okay. Once again, for those who were not there when I introduced myself, I am Dr. Mrs. Comfort Ekanem, the Permanent Secretary, Cross River State Health Insurance Agency. Aligning with all the other panelists have said, I want to say that success stories of the beneficiaries of the health insurance scheme will be an added advantage to improve enrollment, because the next door neighbor wants to hear that his neighbor has accessed such services and has also had positive reports. So when you put out success stories there, it will ginger others. It will be like a catalyst, because apart from the state-of-the-art facilities and the issue of health personnel, the manpower we are talking about, people believe their neighbors. They believe the stories of members of their communities. So we really need to go out there, get the success stories of beneficiaries who have used or accessed the services in the facilities, whether it is that of the basic healthcare provision funds, which is at the community level, the primary healthcare level, or that of the formal sector, which is at the secondary level. And I don't know if there are states that have started the informal scheme. Us in Cross River State, that's the ground we want to break, the informal sector. So when you get these success stories and put them up there, people will see it and they will believe that it is true. You know, I was opportune to meet a panel for a certain interview. And right there, when I introduced myself as the Parent Secretary Health Insurance Agency, a high-ranking civil servant in that panel said to me, "Is that thing working?" Now, which means that that person has not heard the success stories. And still in that panel, two people simultaneously now said, yes. In fact, they told me, "Madam, don't talk, we'll speak for you." Because they have accessed the services and they have success stories. So we should target success stories at the primary level, at all levels where we are providing this health insurance to the people. Then the success story can be electronic media, print media, and using all the social platforms that people can have access to. And before you know it, they'll be knocking at your door to get enrolled. Then another thing we are doing is, I use the phrase when I addressed my management team 2 days ago, that if the mountain does not go to Mohammed, Mohammed should now go to the mountain. So what we are doing now, starting from tomorrow, we are dividing ourselves into sub teams and go to all the places where people are, and we enroll them, give them the information, show them the success stories, and get them enrolled. Because from my perspective, health insurance is the gateway to universal health coverage. Health insurance. In fact, if we get it right, I want to use this word, that you may not necessarily need government funding again if the people buy into it. The last speaker spoke about the informal sector. We all know that the informal sector is where the market is huge. So if we can break through the informal sector, then we have gotten it right. So how can we now make the registration procedure simple? First and foremost, we have to simplify whatever means we are using to register the people. Are we using analog form? Simplify the information. Are we using software? Don't make the information in the software to be too technical. And then it should not be something that you keep the enrollee for long. And like I said, the team enrolling, the ICT team in any of the state's health insurance agency should move out, go to where the people are. Take the product to the people. When you take it to the people, you have their buy-in. As small as 50 naira transport, which is no more there. In my state, there's no transportation that you can pay 50 naira again. The shortest distance is from 100 to 150. As small as that amount is, you may be surprised that the target beneficiaries that you're looking for to enroll may not have that money to pay to where you have stationed your registration stand or enrollment stand or your office. So you have to take the product to where the people are, where the people are living, and then you now be the one to spend your time and then enroll them. So anything that can be simplified will be utilized effectively. But when it is complicated, already the system and the economy of the country is already complicated. People are on edge. There are some people that will tell you they have not eaten for the past 2 days. So when you take complication to them, they will tell you, please come back next time. But when you tell them that this registration will take at most 5 minutes, 10 minutes, at least 5 minutes, they will want to give that time. And then you now do it snappy. So all hands must be on deck. And we also know that sometimes technology fails. So you have your backup, which is the hard paper, the analog. When you get the information, then you can go in and key. And then if there are many to be enrolled, to be registered, then different hands can be using the analog, which is the form, and getting the necessary information that you can key into the system. And we have handsets today. When you train the team that are going out, they can be snapping and taking their pictures, and then you upload it into the system, and it's done at your own time and your own privacy. So that's my contribution for now. Thank you for giving me this opportunity. Over.
Thank you so much, ma. Received. So thank you so much, ma. Two things you mentioned that got to me is success story. And just like I mentioned earlier, when people see things or they experience things, they get to, it's more like a referral system. People want to associate to success stories. So, and I think if we have a lot of success story, people talking about how they have been able to achieve or experience good and quality service, it just gives other people confidence to be able to enroll. And then you mentioned, improving the system. Just like you said, if Mohammed don't go to the mountain comes to Mohammed. And a little change of say maybe 50 naira, 100 naira can be a challenge in subscribing or onboarding to the health insurance. Thank you so much. That was really, really, really deep. Thank you so much, ma'am. I can see some hands up. Mr. Dolapo Komolafe, you want to say something? You can go ahead as well. Dolapo Komolafe. Okay. So just like I mentioned earlier, we'll soon be rounding up because this is like 90 minutes already into the conversation. Is there anybody that wants to talk about enrollment, simplifying enrollment? Anyone?
Okay, I'll just go straight to the point. Dr. Vetti, thank you so much. Always good to hear from you with all your wealth of knowledge. Thank you, and thank you. One other ways to also, reduce the burden of enrollment is to have self-service. But in that, you have to consider the literacy level or the ICT savvy level of the people. All right, we've done that, but I don't know whether it has made a significant improvement in enrollment. So what I mean is that people at the comfort of their home can enroll, fill their forms, and even choose a facility. They just go to edostate.edhic.com, and then the portal takes you, directly to enrollment. You can also pay. Self-service is also there. We've shared we have API with InterSwitch on Remitter platform, Paystack, and so you can use your MasterCard, your Visa card to pay for your health service. But what we're trying to institutionalize is that we're trying to use POS stands such that once they fill their form, they can pay from the POS stand. We've started a pilot program and we're watching it. We started about 2 or 3 weeks ago. And so we hope to extend it to about 1,700 plus POS stand across the state so that, enrollment can be anywhere, anytime, and and also at any space. All right. And so one of the things I talked about earlier, talking about technology, that we leverage on technology from the beginning to the end. Even as it relates to our accreditation process, our monitoring, all right, our enrollment, we use technology. While we're able to get those numbers, if you calculate, enrolling that amount of number, it might be difficult to meet your projection or what you want to aim at. So if we go to a place, for example, if you're onboarding schools, if you're onboarding a particular facility with high numbers of people, you just pray that they already, have an ICT or electronic records. And so what you just need to do is to call your engineer to build an API where they can import most of their bio data into your system, and then put an edit profile such that a particular field that was not imported, maybe, for example, your ward, your local government, your genotype, if it wasn't uploaded, those people who can edit their profile can actually, make it right. Because one of the things or challenges we find in getting health services is that when people go to the health facility, sometimes they're not able to find out whether they've been enrolled into the scheme, whether they're active in the health insurance. And so, that causes a lot of mayhem. So for us in those states, we also have a website that people can just put their phone number or their corporate insurance number Once you type in your details, it shows you your beneficiary, it shows you your facility, and then if you want to get your medical record, you apply for it, and it sends you a one-time password. Once you receive it, then your personal medical records come to you. All right. So in using technology to leverage that, we also use electronic ID cards, so that when our enrollees go to the facility, they can also show their ID cards, electronic ID cards, use a QR code to scan it, and then all their details just show up. So technology again is what we should leverage on in increasing the numbers of enrollee, and also across the spectrum of care within the health space. Thank you very much for giving me the opportunity again. Thank you.
Thank you, Dr. Rock. That was like I said, and just like you mentioned, collaboration technology will give us access, improve access for enrollment, and even more for enrollee management. And that was great. Thank you so much. Mr. Simon Oyemechi, MD of Anambra State Health Insurance. Good morning. Apologies for for the delay in giving you access to speak. You can speak now, sir. We've talked about a couple of topics, but you can, just go ahead and meet us anyway.
Okay, thank you so much, and everyone. I'm happy to be here. Yeah, I'm happy to be here. I'm so sorry because I actually joined at 10 a.m. But then it became so. I mean, for whatever reason, at a point I had to leave. But now I'm here, and thank you, Dr. Rock and Dr. Vetti. I've heard when I joined back now, I heard from where you were speaking of. So just to say that for some of the things I hear around the table, we are already doing quite a number of those things. Anybody on the call can actually dial on any phone at all, USSD code *6700 *005# and send it. No matter the phone, no matter where you are in this country, you can actually be registered irrespective of the mobile network. And you can start registration on Anambra State Health Insurance Scheme from start to finish. Now, in the last 5 years since I've been in the saddle, we have been able to move a state that had zero registration to where we are today at over 200,000. The last statistics I haven't pulled up this morning, but we are well over 228,000 beneficiaries, active beneficiaries across the state. And the magic for us is what we introduce, which we call the adoption model, where we encourage people who have money and have the means, philanthropic in nature, to actually go back to their various communities, families, and what have you, to then pick up individuals who cannot pay their premium for themselves. 12,000 Naira premium we have per person per year to cover a wide range of a benefit package that really covers a lot of what people need to do. So, yes, that has worked for us. And then having that working so far, we have, through that, had a lot of individuals coming into the informal sector. Our informal sector, where we are now, is at over 67,000 Anambra residents in our informal sector program. That for us is actually unprecedented. Over 65,000 people paying 12 certain expectations, they will never come back. So for us, what we are doing with returning clients is a best assessor for us of how well or how badly run the program is. Now, having said that, we have tried over the years to try to improve on our systems to see where we are with regards enrollment, and then to drive up that number. But driving up the number alone does not give you universal health coverage. It is very clear. There is none of the 16 indicators of UHC, depending on who you are looking at, or 22, depending on who you are citing, gives you the coverage as part of indicators that point towards success to UHC. Because it's not just about individuals having access. People can have access, but they never use it. When they don't use your services and they still go out to pharmacies to pick up drugs on their own, or go to patent medicine vendors or even patronize traditional. You haven't achieved a UHC. UHC is that time when people get services, to needed services, and the health needs are as determined by healthcare professionals, public health professionals, not what the person thinks is his need. Now, that tells us how important it is to look through the blue box of health insurance, of universal health coverage, and what have you. Now, in looking at the blue box, you must think very clearly: where are we as a country? Where is out of pocket as a health financing mechanism? Where is a tax-based financing as a healthcare financing mechanism? And where are we with health insurance, which for us in Nigeria has at this point looks to be our own pathway that we have chosen, especially when you look at the National Health Insurance Authority Act of 2022 that has now made health insurance mandatory as a vehicle for Nigeria to attain UHC. So you begin to now ask yourself, how innovative can we be if everybody who is a civil servant assesses health insurance and those in the informal sector cannot come on board? Then we cannot talk about UHC because there's no financial risk protection, which is a key element. And people will keep being pushed into impoverishment and what have you. So we need to make sure that there are schemes that work. And for schemes to work, we must make, like I had when I joined now, enrollment easy, which in Anambra we have tried to do with things like what I told you about, the *6700 *005# USSD platform, which can, with that, we have vendors of our vouchers across the state. We engage with people who have who do POS services across the state to actually register people when people get there. But for those who do not want to do that outrightly, we have decentralized offices, because no matter what you do with technology, there are individuals who will not use it. So you want to save people costs, but they tell you clearly, I cannot do this. And then, yes, for literacy level and what have you, if we can do it in the South, sometimes I think in the urban areas, I beg your pardon, what about in very interior rural areas? So you must consciously decentralize your services. We have decentralized, and then we have tried to engage traditional town announcers, these guys in various villages who go about with one rickety car announcing, oh, tomorrow this family is having funeral and what have you. We have engaged them. In 16 local governments, or in 14, I beg your pardon, of our 21 local governments, we have covered 2 senatorial districts, and we are seeing the tremendous impact of that kind of approach, because we tried to engage CSOs over the years to see if that was going to be a game changer. That didn't give us the kind of success we wanted, because people tell you we are CSOs. I'm sorry, but at the end of the day, people are looking at what is in it for them. Then we have tried also to engage healthcare professionals, such that at this point of our about 230-something healthcare providers, about 100 of them are actually enrollment sites for the scheme. So these facilities are scattered across the places. Of course, we do end-to-end electronic. Nobody uses paper for anything in my scheme. Now, in all of those, their premises, we have created for their desk officers, for the 100 of them who we first used to onboard last year, but we are looking at expanding that to every facility. We created registration portals for them on our platform, where they can get people come in, and then the people register from start to finish at that level. And then we just do ID card printing at the central office in Oka, and then begin to distribute across the state. So that has helped us to ramp up the numbers. But most importantly, we have just recently introduced a tax for service model. I mean, as recent as October last year, but that has gained traction at this point. People are riding Okada. People ride keke. People are bus drivers in the state. These individuals will never come into your health insurance, no matter what you do. The health belief model clearly shows that these individuals will rather go and do what I prefer to call cash and carry healthcare system than to have a health insurance, because we've engaged traditional rulers. Most times when I hear a lot of, oh, have you done this? Have I done that? To put it very mildly and in all humility, I can beg boast to say there is no strategy we have not adopted in Anambra State. We're talking to traditional rulers, going to their palaces in their various villages, going for traditional events, going to August meeting in every community, penetrating the church, using a platform where we gave discount to all Catholic clergy in Anambra State. Every Catholic clergy, apart from Onitsha Diocese, Waka Diocese, Ekulobia Diocese, Nnewi Diocese, all the Catholic clergy in 3 out of the 4 dioceses are with us. Of the 9 Anglican dioceses in the state, all of the clergies and their families are with us as we speak. So these are influencers in the communities that mount pulpit to speak, and people will get to embrace any kind of scheme. So we decided to go with discounts for those individuals. Gave them discounted premiums such that, and then after giving them the discounted premiums, we have tried our best to insist on our service level agreement to be a bond between us and the enrollees and the healthcare providers, such that you don't do anything right, we yank you out immediately from our scheme, or you pay certain fine, as the case may be, to ensure that people keep getting value for money. That way, these influencers in various communities, traditional, religious, and what have you, can continue to reinforce our message across the state. But wait a minute, after you have done all of that, there are 1,001 individuals, because we've done knowledge and awareness as well as practice study for ASHA. Our agency is one that is very deeply rooted in research. For whatever we do, we want to generate evidence and then ask questions so that we can learn, unlearn, and relearn. Now, to that extent, we did a lot. We have done a KAP that has over 4,000 respondents. And people are aware. Awareness is not an issue. But then are they keying in? No. What are the reasons why they are not keying in? Those were some of the things that informed this decision of getting the USSD code, as well as the web format where people could start to finish in their bedrooms, pay, register, and all of that. Now that is solving a problem. But then when we realize that all of this will not work, given the peculiarity of Nigeria, we decided to introduce the tax for service model. So all of these transporters you have in Anambra today, the amount of money they pay on daily basis at their various loading bays, we have increased it. We divided our 12,000 naira by 20 working days in a month, by 12 months, and that gave us somewhere in the range of 40-something naira. Now we had an increase by 50 naira to all of their daily loading bay tickets. So when they finish paying that money, the Internal Revenue Board and the Accountant General Office reconcile, and they pay Anambra State Health Insurance Agency those deductibles on monthly basis. That way, in the last 6 months, we have been able to bring commercial transport workers on our scheme. I think about 3,800 now, because having done this, you will expect that, okay, the governor has announced to them, I'm giving you free health insurance. So on one hand, they are not aware they are paying for it. We have rather increased that their daily docket fee by extra 50 naira across board, so that we can give them free health insurance. Expanded our benefit package for it to also include ORIF for them, that's open reduction internal fixation for when they have accidents and what have you. But we have to go to their loading base to still beg them to register with the scheme. So you see that there's a lot that needs to be done with regards awareness creation. It's not just enough to think, oh, you have created awareness, you are doing a lot with quality. But at this point, to increase the numbers, we needed to start encouraging them. We did a campaign for 2 months to encourage those who registered initially to start using the services. Can you just go to that facility you chose to just try it out? You know what? About sometime 2 weeks ago, I was in the office and somebody called me and said they were in a keke, and the shuttle rider, the keke rider, told them about Anambra State Health Insurance Scheme, that this thing works, that when the state governor was telling them he was giving them free health insurance, that they thought it was one of the scams of government. Because we should not be lost, this shouldn't be lost on us. There's a lot of mistrust for government and the services government has to offer. Over the years, those of us in government and those who were in government before us have really destroyed the trust of the people once government says I'm doing anything. To that extent, people are not interested in what government wants to do or has to offer. So we encourage these individuals to go to hospital, and the message today in the state is this free health insurance thing is working, and for you, you just need only 12,000 naira. And these guys are now asking us for our flyers through their union leaders to say, we need these flyers. People that we carry every day, in our commute every day, are asking us how they will register. So since this new policy direction has come for us, we have had quite a couple of persons coming. So it's not a hard and fast rule. You must begin to try this option, try that option, and over time, you get people to use the services. When they come on board, insist that they should go and use the services. If you try that and they get value for money, then truly you can begin to move people away from a time when they will have a health insurance policy, but rather still go over the counter and still keep doing out of pocket health expenditure and see your insurance to be of no value. But sanctions must be appropriately handed down to erring facilities so that we can actually regain the confidence of our people. I've heard quite a lot about PHC and what have you at the beginning, but let's not comment on that because somehow Dr. Rock touched on it, and then there's a doctor from National Hospital who also touched on it. If we don't have health centers to work, we cannot push people to just go to health centers. We must have health centers to work because there's a big difference between primary care and primary health center. Primary care can actually happen at any point, at any level in healthcare, but we don't want it to happen at tertiary facilities. But at private hospitals and all of, but let's not get into that. I think I may have lost certain things that must have been discussed along the line. Yeah, thank you, and I'm sorry I had to join in very late.
No problem, sir. Thank you so much, Mr. Simon. That was really, really, encompassing. I listened through all the things that you mentioned around in the process, the strategy that you employed, in enrolling people, and then how you try to break barrier and challenges, and then to ensure that people trust the process, trust the products. I must say that Anambra is doing an amazing job in terms of, encouraging and building that trust between trust for the product. And thank you so much for that. The data you shared, the strategies you shared, the encouragement, because, to some people, it's a hard sell. Insurance is a selling promise. And so, encompassing all these strategies. If they see somebody talk to them on radio, somebody say it in the keke, somebody says in the market, they talk to them about in their corporation meeting or their association meeting, it sticks to their head. They try to, okay, what's this about? And then encourage people to, enroll to the service. Thank you so much for that, contribution. We are really, really grateful for that. Mr. Bala Seidu, you wanted to speak. Are you on now? And apologies for keeping you waiting. Apologies for that.
Honestly speaking, I started thinking that the panelists should be giving a specific time to talk because others may be on the queue or engage in other activity and they want to also put their own contribution. Thank you so much for the well-thought presentations and discussions so far. But I just want to start with one thing. If you do a thorough literature review of how the health insurance has been in the world entirely, where they achieved even the universal health coverage, you find out that there is never a place where a voluntary health insurance ever works. Every way that the health insurance has recorded a tremendous success, you find out that it is through compulsory or mandatory health insurance, which I think the Nigerian government is now moving in the right direction by signing the 2022 National Health Insurance Authority Act, which now make the health insurance mandatory. Because once you make it mandatory, then people will now begin to voluntarily come on their own to register with the scheme because they now see the consequences. But the greatest thing is also the implementation, how it will be implemented in the country. But by the way, you see that here in Kaduna State, we categorize our populations into not just formal and informal sector. We have the formal, then we have the informal sector, then we have what we call organized private sector. As the Anambra man now, the DG have said, most of those Kekenepep and other people that are working in an organized sector, if you want to now get them a role, the only thing that is most efficient is just a common policy statement from the state leaders, political leaders, maybe the governor, just to make it okay. Let's now attach their own license renewal, or if you want to enjoy any service in the state, you must now present the evidence of registration with the state social health insurance. Even the Okada man in the state, if you want to now go for an Okada rider, you have to register. You have a union. Even the NURTW, that's the road transport workers, they have union. They do registration with the state government. So before you do the registrations, you have to now present an evidence that yes, you are now registered with the state social health insurance. So this is one of the strategy that we are trying to adopt, though it is not yet been actualized, but I think it's one of the most important way for the social health insurance to make progress. Another one is that you look at somebody has emphasized on the success story. The second person to the last emphasize on the success story, and then the way you get a good success story is when you develop a good rapport. There is one business saying that a satisfied customer is a free sales agent. If you have a customer that is been duly satisfied, that customer will go and sell out your product without any difficulties. And how can you now get customer to be satisfied? In different fora, when there is engagement between the state social health insurance actors in the country, you find out that one of the challenge maybe is the quality of the service provision. Most of the facilities that are engaged, that are registered, they tend to turn down or treat our enrollees with leniency or even with disregard. So if there would be a strong collaboration and understanding between the healthcare providers and the state social health insurance actors, whereby all those that are already enrolled will now get the quality service, it will now make it very easy for the scheme to make a progress. The third point is still on the political will. We are talking about the awareness creations, because people need to know that you exist and this is the value that you have for them before they enroll. But when there is no strong political commitment, particularly in allocating enough resources, because all these awareness creations is very costly. If you look at it here in Kaduna State, the person, Dr. Hamza Ibrahim, that represent Primary Healthcare Board, he made mentions of the community volunteers. We have over 3,000 community volunteers. These are the people that has been trained to now demand for polio vaccine, demand convince and then now mobilize people to accept them. So they have this knowledge of demand creation. So now, okay, the scheme want to leverage on their existence because they are everywhere across the state in their own various locality. But you need a good amount of money, a commitment for the government to support you so that you can be able to engage them, train them, and then they will now go back to their locality. What we now want to do also to ease the registrations, there is other issue, digital innovations. What we have, we now created what we call e-wallet. E-wallet is just a process whereby you pay your premium on an installment basis. Instead of you to come and pay 10,650 naira for an annual premium, then we now decide to open that e-wallet account where you will now be depositing small amount of money as you get. Once you reach up to the 70% of the premium, you will be registered. You will start assessing care while you will continue paying the balance to for that particular year. And then at the same time, we look at our own community because we are agrarian state. Most of our people engage in agricultural activity. Then we now say, okay, let us now bring out an innovation called Produce for Health. Produce for Health is just a situation whereby during the harvesting period, the majority of people are rich and they have an abundant amount of money. So therefore, we can collect the produce of their farm, we now register them, we quantify it, we register them. Then you see that a farmer can voluntarily give you without difficulties a bag of maize, a bag of rice, 2 bags, for him to register himself and his family, and without difficulties. So therefore, we also have this innovation. And at the same time, lastly, we have what is called Kachma house to house. It's just the issue of bringing the scheme closer to the people that it intend to serve, whereby people in the community will now have our registration center in all 255 political wards. across the state. So therefore, if you want to register, despite having some mobile application that somebody can access and register, then you now have an agent that is close by you, that whenever you have any difficulties or you want to register, you now go and get and contact him, then he will register you. So therefore, we'll make it seamless and easy for the intended beneficiaries. Lastly, I want to suggest to those, the organizer of this particular wonderful program, that this kind of advocacy should also be taken to our own governors for them to see the importance of healthcare financing through social insurance, to make it as one of their priority projects. Because if it is adequately taken care of, the healthcare, the state social health insurance can be able to finance the entire health system, health sector of a particular state and of the country entirely. So thank you so much for the time given to me.
Thank you so much, Dr. Bala. This is so, I like the way you started the conversation around how can we, move from paying out of pocket for insurance to maybe bundling it. And I like the way you share your point, how you've been able to overcome this inertia around, out of pocket. And so I just want to say thank you for your contribution. This is really, really, eye-opening for us. And just like you mentioned in your last statement, that we need to take it to the state governance. And that is one of our projects as well, to be able to, bring about this political will, for them to be able to, support the drive, because it is very important that they understand the importance of having this health insurance, coverage for majority of their population. And so we're coming to the end of the conversation, and I'll call on Dr. Ekpeme Neto, the CEO and founder of Wellahealth. You've listened to all of this amazing this eye-opening, mind-opening, comprehensive conversation around health insurance in the state and what they've been doing to achieve an amazing feat. And for people that have not started, how they've listened to the success stories and how this is very important for them to start and be able to, be successful at it. What is in place where does Wellahealth come in all of this? How can Wellahealth support for those that are working, for those that are, struggling, and for those that have not started yet? Dr. Ekpeme Neto, the floor is yours, please.
Thank you so much, Larry. I hope everybody can hear me. I want to say a huge thank you to everybody that has attended, and for the amazing contributions you've all made. My heart is full and energized, in fact, by the things I'm hearing. And honestly, I would say that some of us are not even aware of the things that are going on. So I'm really pleased to hear of so many amazing efforts that we are all putting in. For us at Wellahealth, so we started out with trying to improve healthcare quality. So, I trained as a physician myself, abroad, and I always wanted to come back to Nigeria to improve, healthcare. It was when my own mom, started to have challenges with accessing healthcare. I said, okay, this is time to return home. And as I made that journey back, I decided that technology was the way to do it. As we started to build technology and, we tried to sell it to patients, then to labs, then to pharmacies and even doctors at a point, doctors, clinics and hospitals, we found that there was a common thread, there was a common problem, and that was really the barrier of financing for healthcare. And so that's where we said, okay, we need to go and work on financing and figure out how to improve the whole system so that everybody has kind of more money to play with. So that was the origin of our own journey into figuring out healthcare financing, working with insurance, etc. Our work has been in the private sector. So we work with over 25 insurers, been able to service somewhere around 200,000 patients, work with over 2,000 healthcare facilities, work with enterprises to distribute healthcare insurance even. So Airtel, MTN, banks, Stanbic, First Bank, etc. So we've done a lot of work in the private sector. But as the new, National Health Insurance Act came into being, and the amount of focus that's been put on the state health insurance schemes, we felt that actually it was time, for us to take some of those learnings that we've gotten from the private sector and try to support, the work that's being done in the public side. Hence the origin of this. And so we sought to put together this report and sought to build relationships with yourselves here to first of all learn, see where the gaps are, and see where we can come and support with some of the learnings and the resources that we have. Some of the learnings that we've gotten from the private sector. And so I'm so delighted to hear of, some of the progress around technology in Anambra and Edo State. Kudos, and, would love to learn more and see how we can lend our support there. But to, other states that are looking at how to solve some of these problems around low enrollment, around the quality of service, around even, making payments to be a bit more affordable on a, say, monthly basis. Those are things we've all done in the private sector, and we'd be willing to work with, you all to actually, help and support. So really excited about this, and also want to be able to tell the stories. I think one of the things here, when you get reports, we want to be of the success, and hopefully that helps to then inform, the political will. Because I think that there is a huge win politically here. There's a huge story that we can give to the the governors of our states that helps them to project themselves in a better light around how healthcare access and healthcare adoption and health insurance is really helping. So I'm so excited about all of this, and we look forward to supporting and helping as we go along. So thank you again once more for joining and for sharing, and we hope to do this more regularly. The reports, we're committing to do it annually, and we're committing also to telling these stories regularly as we go along. So once more, thank you so much, and we look forward to working together.
Thank you so much, Dr. Neto. That was great. And please, we shared a link to the chat. Please, please help us to fill it, the form, so that we can share with you the report that we've designed and worked on the state health insurance. I see a chart that says Kaduna State Contributed Health Management Director General is in the call and raised his hand, Abubakar Hassan. Yes, so we're about to close, but I have to give the mic to you. You've been trying to talk. Please, if you're still on the call. Yes. Good afternoon.
Yes, I'm right here. Good afternoon.
You're welcome, sir. Yes, sir.
Yeah. Well, whatever I'm going to say, I'm sure my colleagues from the other states, Dr. Rock, my brother from Anambra, have already spoken about it. My own take initially has just been spoken by your CMD, where he says this call or this sort of engagement will be a regular phenomenon. I was going to say that I'm hoping that it is not, this first call may not just necessarily be a tick in the box and then you have all the information you require to push, but regularly means that this will be the beginning of more further engagement, where we will need to create avenues for us to begin to engage and dialogue with the governors forum, so that we can begin to harness that political will across the entire country for the social health insurance scheme to really begin to go to where it's supposed to be. I can tell you that, just like my brother from Anambra said, we've done a lot in terms of innovative measures to be able to see that the numbers are really going in. But as of today, those numbers are still where they're supposed to be. So I'm hoping that the regular engagement, like you have just mentioned, will help us to be able to drive and find cogent reasons to put up propositions to the government, either at the national level or at the state level, to see how we can enforce. And just like my Kaduna brother mentioned, it is that enforcement that really brings about the success of any social health insurance scheme across the world. So my tip is that I want to thank you all for setting up this agenda now. And I'm hoping that it will be the beginning of our more success within the health insurance scheme. Thank you so very much.
Thank you so much. That was concise. Thank you so much. Just like you mentioned, and the CEO mentioned, it's not just a one-time thing. It's more like an avenue where we all share, experiences, success stories, and opportunity that we are actually leveraging in our states for us to be to be able to take it to the political guys so that we can have, a success story at the end of the day. I think one or two persons want to say something before we close finally.
Sorry,
Okay.
I wanted to say I haven't seen the link. My chat box is not enabled. I'm not sure why. Julius talked about link for a form or something.
Yes. Okay. We'll just send it to you. Maybe via your message. We'll just do that. But please, if you can see the form, if you can fill the form, it's just request for your name, number, email, so we can send you the report that we've designed for these events. Okay, thank you all so much for your time. This is really, really amazing. We're happy, we are grateful for your time. We say thank you to everybody that have shared one or two things. And for those that are listening as well, we say thank you. Well, we couldn't take all of your questions, but we promise that the next event will be much more, more engaging than this one. Thank you so much for your time. Thank you to everybody that are present. Thank you for, sharing your thoughts, your experiences, and the rest of that. So say thank you so much. So, on this note, I would say we are coming to be at the end of the the webinar, and we'll put it at a close. We'll be engaging you guys on a more personal basis. Julius will be reaching out to see how we can explore opportunities to improve, to kickstart, and to make better the health insurance in all of the states. Thank you so much, and have a great day and an amazing rest of it. Thank you. Bye.